So hi everyone, thank you for having me. I'll be talking about headaches in children and I'm happy to be interrupted if you have any questions, and hopefully will be some learning from this session. So, so headaches in children. So it's one of the diseases that it's actually affects a huge amount of children and has a huge impact in quality of life, not only for the child but also for the family with missing school. So it limits their activities and their social interaction. It causes school absenteeism and consequently lower learning outcomes that this child would be able to achieve. And especially in the teenage years, there is a huge risk of dropping out of school, and also an effect on the parents as they have to be with the child or pick them up from school. So overall, 12 to 15% of the children at school age will have headache at some point in their life and be seen by a primary care. And on the teenagers, this is much more frequent. Around 49 to 50% of the teenagers will have headaches that will need at some point some assessment. And when we look at what types of my headaches, so the secondary headaches are between 20 to 60%, and the primary headaches are much less frequent. So if you look at what is going to come to your door or to the emergency department door, so headaches are 1% of the emergency department, and I'm pretty sure on the GP surgeries are a bit more than that. And 20 to 60% are secondary to viral illness, minor head injury, sinus infection, ear infection, vomiting and diarrhea that comes with headaches. And just 20 to 30% are primary headaches, which are migraine, tension type, and the trigeminal autonomic cephalalgias. And just a small percentage of all of these will have significant neurological impairment that will require admission to the hospital and immediate attention. So if you think about that, most of the headaches are secondary to an infection that will never reach a pediatric neurologist at this point. They're all going to be under primary care. And especially in the preschool children, and they are related to viral illness. When they are getting older and getting to the teenage years, that becomes more frequent, being a primary headache, not a secondary headache. So what are the red flags? I think you all know about it, but just to recap. So anything that will worry you that this might be something that needs further investigation or needs imaging or a trip to the hospital. So if they are acute and severe, and even though this could still be a viral illness or nothing sinister like a meningitis or a brain tumor, that's something that you should be more concerned. Any headaches that wake the child up in the middle of the night or early morning with vomiting, this is a sign of raised intracranial pressure, and we'll need some further investigations. And recent onset, it is a red flag, but in the end of the day, you can have migraines that just started in the past 6 months out of the blue. But I think what we need to worry is if you have a worsening pattern, they started 6 months, but now they are much more frequent. They are becoming every day. They are waking up in the middle of the night. If they are worse when lying down, or bending down, or straining, or coughing, this is all signs of raised intracranial pressure as well. And one of the things that we see as well is a changing behavior in demeanor and worsening in the performance at school, or quite lethargic and sleep during the day. And you always have to consider a child who already has a diagnosis of migraine or tension type headache, that the character changes. That's something to be worried about as well. And in the under twos, you always worry about hydrocephalus, or increasing head circumference. abnormal growth of puberty is going to, you worry about craniopharyngioma. If they have any neurological signs which are new, this is a concern if there is a brain tumor. And patients who are high risk, like sickle cell anemia for strokes, malignance, or a recent head injury, that you can have concussion syndrome and a post-trauma headache. If they have a VP shunt, and if they have a recent onset of seizures, and neurocutaneous stigmatas if they have something growing as well that causes raised intracranial pressure. So I think one of the most useful things for parents is always to be aware of the Head Smart. I hope you all know about it. It's about the charity for brain tumor, and they have very nice information on the website, and they divide by age, like in under fives if they are with persistent vomiting, if they are off balance, they have abnormal eye movements, if they have become lethargic, if they had any fever or any seizure without a fever, or if they had a head tilt that is or a stiff neck, that can be a sign of a space occupying lesion. In older children, again, headaches and vomiting, coordination problems, abnormal eye movements, and fits and seizures. So, and in the older population, it's basically very similar symptoms, and just be aware that they will have abnormal neurology. So that's your red flag. What are the life-threatening headaches? The big elephant in the room when a parent take a child to your practice is, does my child have a brain tumor? It's always their concern. And that's when you have to feel confident on your history and your examination and knowing what's going on, to say actually there is nothing to indicate there's something like this. And if they have meningitis, this is a life-threatening condition, then it's treating ventricular a VP shunt if it's infected or blocked. This is an emergency as well. If they have venous sinus thrombosis, if they have an acute headache and then stop moving half of their body, and dissection if they had been playing on the trampoline, fell backwards, hit their neck, and then develop a hemiplegia in one of the sides. So there are lots of things that you will be worried, but the history will usually be quite clear and give you indication that actually need to think about something else. This is not just a simple headache. And I think the biggest thing is to be sure if it is a primary or a secondary headache. And I hope you are all familiar with the International Classification of Headache Disorders. That is a very nice website that gives you all the diagnoses and all the criteria, and even give you some management for that, and that applies for adults and children. So it's quite useful to know about it. So what are primary headaches? Primary headaches are migraines, tension type headache, trigeminal autonomic cephalalgia, and other primary headaches that will include possible migraine, likely tension type. So it's the ones that are a bit uncertain, but you still think they are in the same umbrella as a primary headache. So what are the secondary headaches? These are the headaches attributed to any head injury or any vascular disorder, a non-vascular intracranial disorder like raised intracranial pressure for IIH, to a substance or withdrawal like carbon monoxide, meningitis, and other types of headaches. So just to illustrate, so we have a 9-year-old girl with a 6-month history of pain on her head, described just throbbing, sometimes on her left side, sometimes on the right. She feels sick, she vomits, she sleeps for a couple of hours, and then she's fine, and she has a normal neurological examination. Is this a primary or secondary headache? I think you all agree with me that there is nothing in this history that would worry you that she has a secondary headache. And then you have another boy. So 6-year-old boy with a history of headaches, mainly in the morning, associated with vomiting for the past 6 weeks, more recent changing behavior and torticollis. And on examination, he was unable to walk on a straight line. So that's clearly a secondary headache that needs immediate attention. I think one of the messages that I really want to get through today is not all headaches are migraines. So you need to have a bit of a time to take the history and be confident that you are not missing something else and to give the right treatment for this child. So one of the most important things is concentrating on the history, that it doesn't need to be very long, but if you have in your mind what you are looking for, you can get in 5-10 minutes, get the most important points and be sure what you are dealing with. So you always need to think about the attack duration, the quality and the severity, and where it's hurting. Basically, if it is uh, an infection like meningitis, there will be a headache that doesn't go away. The whole head hurts. It's quite severe, and the child is quite unwell. If you are talking about attention type headaches, will be a dull pain that is in there from the moment they wake up until the end of the day. Worst towards the end of the day, it feels like a pressure, and it's usually in the back of the head. And if it's a migraine, will last anything between 2 hours to 72 hours. There is a pulsating character. It's quite severe, but then gets better. So just chatting and having an idea how frequent and what the character of the headaches and duration, that gives you a good idea what you are dealing with. Relationship to posture and coughing is, does the headache wakes you up in the middle of the night? Do you have to sit up in the middle of the night for your headache to get better? Do you vomit in the morning? When do you have a headache when you triggered by coughing or exercise? What makes it better? Does laying down when you're sleeping helps? That's towards a migraine. Does doing PE lessons just trigger your headaches? That might be a migraine. They are light and noise sensitive, it goes towards migraine as well. And what triggers? And if you didn't sleep well, if the child is worried during exams, is missing meals, if it's having any change on their routine, and also the pattern of the headache. If this is progressing and getting worse, then you need to worry about something else other than a primary headache. And when you look at other things, kids with headaches, they will have other symptoms together. You look at the child, they are usually pale, they usually have dark circles. The headache is affecting their sleep and they feel fatigued. They might have fever, they might have confusion. And in some of them, when you are talking about migraines, they might have some visual aura. Sometimes we just have dizziness and vertigo. And some of them, more rarely, will have some speech change before having the headaches. So, and in terms of past medical history, you need to look for anything that will give you any risk factors, like having VP shunts, if they are obese for a age, if they have any head trauma in the past, if they are on drugs, or if they have any other systemic diseases. On the secondary headaches, what do you need to worry? What they are acute severe headaches? Is the infections, the venous sinus thrombosis, or the bleeding on the brain, which they will be quite dramatic and difficult to be missed. The child is usually going to be quite unwell in front of you, and the headache's not going to subside with painkillers. So it's easier telling and teaching you like this, but in clinic sometimes you might doubt and not be sure exactly what you're dealing. And I think if you are in doubt with a child with a severe headache, you have to think about referring or investigating before you just consider this a migraine. So in the chronic and progressive headaches, you are always going to think about your brain tumor, but if they don't have any other neurology, abnormality, weakness, abnormal eye movements, head tilt, the chances of this being a tumor is very small. So the brain tumors, this is from papers, And 98% of the brain tumors will have some neurology abnormality on the examination, but you do have 2% that will have just headaches. If they have a VP shunt blocked, they are going to have usually chronic headaches with acute symptoms and vomiting, and usually these children have a long history of problems with the shunt. And idiopathic intracranial hypertension is something that you have always to think on teenage girls and boys, especially if they are obese. And it's a headache that can wake you up in the middle of the night, has all the symptoms, raised intracranial pressure, can have blurred vision, and can have tinnitus, can have stiff neck, and the main treatment will be, if they are obese, losing weight. So just as an example as well, so a 14-year-old girl admitted via EG with a 2-week history of severe headache, ear pain, vomiting, and feeling dizzy. She was treated for an ear infection 3 days before the admission and had a normal neurological examination, but the headache was quite severe and different from her previous presentation. So she had a past medical history of migraine with aura when she used to have blurred vision and tummy pain, and then had the pulsating pain with vomiting and triggered by exercise. And this was happening once or twice a month, and she did have some prophylaxis, but really well managed. And what triggered the admission was because it was a change in her headaches and the severity, and it was a headache that was there all the time, which was severe, with vomiting and dizziness, which was very unusual for her in the background of an ear infection. So this girl had an MRI and an MRV that showed a venous sinus thrombosis, which is a complication that can happen with ENT infections, and was started on anticoagulation. She did need a lumbar puncture at the time with the raised intracranial pressure, more for alleviate of the symptoms and therapeutic than thinking about IIH. And she was sent home. And then she came back to EG, and this time with a daily headache, with an achy pain, different from the headache that she had before and different from the migraines that she had in the past, and was a dull pain that was always in there, and nothing would make it better. And taking history and talking to her, she was overly concerned that she was going to die because of the clot on her head. And because of the family history. So we reassured her, explained the nature of the condition, and it's all resolved. So, and then talking a bit more in more details about the primary headaches. So migraines. So this is from the ICHG 3. So you have migraine without aura, migraine with aura, and then you can divide it in typical, brainstem, hemiplegic migraine, familial, sporadic, retinal migraine. So they are all divided in several subtypes. And this is helpful, so you know what the criteria for the headaches are, and then you know more or less how you're going to treat that. So as a definition, the migraine without aura is a headache disorder that is recurrent, and it can last from 4 hours to 72 hours, the same episode. And the typical presentation is a unilateral pain, usually pulsating or throbbing, but sometimes kids have difficulty telling you about that. They just say it's achy, but they show it's just one side, but sometimes they just have on the forehead. And is aggravated usually by any physical activity, and it has to be associated with nausea and vomiting, or photophobia and phonophobia. So to diagnose a child with migraine, you have criteria. First, this has to be repeated events. You might have a look at a child and the history in the first event sounds like migraine, but you can't give a diagnosis of migraine unless if this is repeating over time. And to be strict on the criteria, you have to have at least 5 episodes with the headaches that are lasting between 4 and 72 hours. They have at least two of the following: unilateral location, pulsating, moderate to severe pain, aggravation by um, exercise, and at least one of the following: nausea or vomit, photo and phonophobia. And you cannot explain by any other diagnosis for headaches. And when you talk about the headache, the migraine with aura, again, so it was recurrent attacks, more than 5, lasting minutes of unilateral, fully reversible symptoms that can be visual, can be sensory, and sometimes just um, it just unusual feelings, unusual smells, and it can be all sorts of things. And usually happens around 30 minutes before the headaches, but can be any time between 5 and 60 minutes, and then the headache starts. Sometimes you might have just the aura and not have the headaches. Again, you have criteria. You have to have a fully reversible aura, like visual, sensory, speech, motor, brainstem, retinal, and at least 3 of the 6 characteristics, at least one aura that spreads over 5 minutes. You don't have a symptom like, oh, I have a blurred vision now and it's gone in seconds. So it's ongoing over a period of time. And you can start with a blurred vision and then have flashing lights after. And the aura can last anything between 5 and 60 minutes. And usually at least one of the aura is positive, like flashing lights or blurred vision, and and usually is followed by the headache anytime between 30 and 60 minutes. But you can have just the aura and without the migraine after, but not in every single episode. You are going to have the aura and then have the migraine on top. So you make the diagnosis, but the parents need to be aware that sometimes they might have the aura and not progress to the migraine after. This is important because when you are giving rescue medication for migraine with aura, we usually advise to give the triptan or whatever you are giving when the aura is progressing and you know it's going to have a headache, because you might take a medication for an aura that might resolve by itself. So, and the headache, it has 4 phases, and this is important because parents will kind of over time know when it's coming. Like the prodromes is very clear when the child is familiar with her own symptoms or his own symptoms. The parents will notice that they are not sleeping well, they are yawning more, they are more tired, they are craving foods, they are more irritable, and this is days before. And then they start seeing the aura, the flashing lights, numbness, tingling, whatever symptoms they have as an aura. And then the headache can last up to 72 hours with the whole shebang, with photo and phonophobia, vomiting, feeling cold, feeling hot, pale and tender scalp. Some kids even have diarrhea during the headache. So, and this can last up to 3 days. And after that, they will feel tired. They will feel unable to understand a few things. It's kind of being quite hungover after the whole thing. So just to give an example of a migraine. So we have a 12-year-old boy who describes his headache very clearly, like a hammering pain on the left side and sometimes on the right. He knows the headaches are coming because he can see waves on inside his head, and then has a blurred vision that it's in both eyes or on the left, and it's usually half an hour before, and the headache comes after that. And he cannot tolerate the light, and he cannot tolerate any noises around him. He vomits several times during the whole episode, and he usually is very tired. and needs to sleep for at least 24 hours. And his symptoms are severe to the point that it's affecting his school attendance, because when he starts, he takes 24 hours to recover after that. And it happens once or twice a week. And they can be triggered by frustration and also for the lack of sleep and other things in this case. So how do you manage a case like that? So this boy does have a clear diagnosis of migraine with aura, and does have the recurrent vomiting, but he's a bit old for the cyclic vomit syndrome, and he has the clear aura, so he would fit more the criteria for migraine with aura. So how do we manage? So acutely, your aim is to keep this child stable. So the first thing is getting the environment, take away other triggers. That's why kids go to a dark room when they sleep and with no noises. And then make sure they are drinking something, which can be tricky if they are vomiting. And then you give proper analgesia. So, and if if they are at home, you can give oral, you can give PR, paracetamol, and you can give both together, paracetamol and ibuprofen, in a decent dose. And if needed, like in this boy, give some antiemetics. You can give oral melting tablets or give oral ondansetron. You can also use any triptans when you know the headache's coming, and they are licensed on the BNF for children over 6 years of age and can be quite effective. And then you have other things coming in the future, and one of the things is do not use any medication with opioids like Migralev and all these kind of things. They might give a bit of a relief initially, but they have a rebound headache after that. It's not indicated, and it's on the guidelines. Do not use any medication with opioids in the acute setting. And if the headache is lasting more than 72 hours, this is what we call status migraines, and they will need hospital admission and discussion with the neurology uh, to manage this further. So, and what about the long-term management? And I think that's what you guys are going to see in your clinic. So you saw the child, you think, yeah, this is migraine, this is quite affecting your life. So we need to think about how to make it just better. And so it has to be a partnership with the parents and the child. There is not one tablet that you can give and everything is going to go away. And so you have to have a pattern and understand what the triggers are, so parents can try to avoid it and the child as well. And you have always to discuss with them about, look, your child has what we call a headachy or a migraine brain. So changes in the routine and on the daily activities might trigger a headache that would not happen to his friends or her friends. So it's really important to have regular meals, not skipping any breakfast, because that keeps your blood glucose stable. And drinking is really important. So make sure you are hydrated. And the lack of sleep is a major trigger for headaches. And the routine, wake up every day at the same time, including weekends and holidays, because the worst thing a child with migraines can do is oversleep over the weekend, stay in bed until 12 o'clock because you didn't sleep well during the week, and this will trigger even more events. And involve the school, knowing if they have a migraine, they can have the rescue medication at school. The school is happy to give paracetamol and ibuprofen, and on the secondary school, even the triptans, as long as they have a letter from the GP or from the pediatrician or the pediatric neurologist saying that's what the diagnosis is, that's how we treat. And usually, if they can do that, the child doesn't need to go home. And then you need to start talking to them about prophylaxis to have the headaches, which to be much less frequent. And then you can use the rescue medication occasionally and then treat with whatever prophylaxis you decide for 3 to 6 months. Then if the headaches are much less frequent, you can stop and observe. So in terms of prophylaxis, there is the nice guidelines that for children over 6 years old. And what it's in the guidelines is propanolol, amitriptyline, and topiramate. And suggestion that the pizoxfen has some evidence and the nutraceuticals as well. But the only three medications that are in the NICE guidelines are these three. In, in clinic, what I would advise you guys to do, and that's what the BPNA special interest group advises, is the vitamins are harmless and 50% of the kids will respond. Some parents will like because it's not a medication with many side effects. And you can give riboflavin, which is usually 200 to 400 milligrams a day. It's going to make the urine darker, but other than that, a bit of a tummy ache, but nothing more than that. You can give it together CoQ10, 50 to 100 milligrams. Magnesium, there are lots of people that think that might be helpful. And if they have low vitamin G, always treat. And because these things, they are joined. It's not the cause, but they are joined. So in clinic, I do use the riboflavin and the CoQ10, and you do any prophylaxis that you decide to give to the child, you give for 6 to 8 weeks at least before you think this failed. And in addition to the other things that you have to get the parents on board with the routine, with the meals and with the hydration and the prophylaxis, and understanding the triggers and trying to avoid this. Pizoxfen is a really good option. It's a medication that it's on the BNF for headaches. You can go to from 0.5 milligrams to 1 milligram, 1.5. Again, side effects are abdominal pain. Some kids feel quite tired. And again, you need to give a good go between 6 to 8 weeks before you think this is not working. Propanolol, it's a good medication for migraines, good medication for tension type headaches as well. You're using much lower doses. You can start with 10 milligrams once a day, and you can build this up to, depending on the age, up to 8 milligrams. And again, you need to give for a good period of time. Never give to a child who has asthma, and advise that the heart rate might be a bit lower, and you might have some symptoms related to that. Amitriptyline, and it's not your first choice, and it shouldn't be, and because of the side effects, but can be quite effective. But usually when you are at the point that you think you need to prescribe amitriptyline, you refer to a pediatrician or for further management. Relaxation techniques works for every type of frequent headaches, and it can be anything that the child enjoys. If they are into mindfulness, wonderful, that works very, very well. If they are into kickboxing and that makes them relax, go for it. And acupuncture is, it's in the guidelines that 6 to 10 sessions are advised and with good evidence, but it's not funded anywhere. Topiramate is a good drug for headaches, but with the recent development that you have to do all the prevention of pregnancy, we are using less and less. And from the BPNA, we are not advising unless you have no response to any of the other drugs in children, especially girls on childbearing age. Right, now talking a bit more about tension type headaches. You're going to see this a lot on your teenage group, and sometimes when you have frequent migraines, they develop tension type headaches as well. So, and you can have infrequent ones, you can have frequent ones, and you can have chronic, and you're going to have those ones that are kind of, but not quite sure they fit the criteria for tension type headache. So this is all from the ICHD3. So it is a very different headache from the migraine and the trigeminal autonomic cephalalgias. It's a headache that is in there always in the background, and it's a grumbling pain, usually between 3 and 4, and usually gets worse towards the end of the day. And most of the time they don't have photo and phonophobia, but some kids will do. And and they are, and it doesn't have any relationship with doing PE lessons or any physical activity. And to give a diagnosis of tension type headache, you have to have at least 10 episodes of that last more than 30 minutes up to 7 days. And it can be bilateral. It feels like a squeezing feeling or a tightening. And it's usually mild and with periods of exacerbation. And usually there is no nausea or vomiting, but sometimes they might have photophobia or they might have some phonophobia. Um, Again, just an example. So you have a 17 years old girl who start having episodes of feeling pressure all over her head with no noise or light sensitivity. They were not every day, but they were lasting up to 2 hours. And she felt this was, and then after that, she felt this was going to improve. And but then they progressed to having daily episodes when her whole head was hurting, a constant tightening, dull pain, and no headaches, free days, and they had periods throughout of the day, and they were not terrible, but with periods of exacerbation, and nothing would improve her pain. Sometimes fresh air or a cold drink, but it's not always consistent. So that is that she would fit the criteria for tension type headaches, and she would fit the criteria for chronic tension type headaches. So how do you manage this? So acute treatment is difficult because the pain is in there all the time. So you basically will have to understand what is triggering the headache, and 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 you can give simple analgesia, but you have to be very mindful about medication overuse. Headache, which is these kids have headaches every day, so they take paracetamol every day. So by definition, if you take painkillers more than 15 days in a month, it means twice a week. That causes you overuse medication, with a constant pain in the background, and you don't respond to painkillers, and you have to advise to completely stop and give at least 3 to 4 weeks with no medication to see some improvement, with worsening symptoms in the beginning, but improvements in the background pain after that. And what you need to tell these patients, it's reassured that they don't have anything sinister, they don't have a brain tumor. This is what we call tension type headaches. And medication is not going to be the answer, and find other ways to to deal with whatever is triggering the tension type headache. And in terms of long-term management, you have to agree on goals with these kids, because there is not one only thing that you're going to do, but you agree with them. What's the most important thing? Get you to school. Okay, then the first thing you're going to try is get you to school with a level of pain that it's bearable for you to be there. And then we'll be getting you to do some other activities and better sleep and all the other things. Referral to psychologists, it's really important. And these kids have chronic pain, and there is something underlying that it's causing the symptoms, and then psychology will be very helpful. Acupuncture is helpful, but again, not funded, and always discuss medication overuse. And then the basic advices are all the same as for migraine. Doesn't matter if it's tension type or if it's migraine. If they are frequent, you have to have a routine. It's important that these kids wake up. What happens with teenagers is they don't go to school because they have headaches, and then they sleep until late. They don't do any activities, and then they don't sleep in the night, and that becomes a vicious circle and nothing gets better. So what I tell my teenagers is, you have to get up. I don't care how much your head hurts. Get up, do something, and get into a routine. Otherwise, I can give you a bucket of tablets and nothing is going to work. And I'm not very happy, but it does work. And it's the continuity of this, and then engaging in activities. And what I say sometimes, that you have a headache anyway, staying in bed or not doesn't make any difference. So just get out and go to class as much as tolerable. And then the prophylaxis for tension type headaches, propranolol is a good option. Amitriptyline is a good option. Relaxation techniques are really important. And I have been using, and there is more and more evidence about melatonin in higher doses for tension type headaches and also for melatonin. The idea is not only by regulating the sleep, it's because of the regulation of the chemicals in the brain. So we're using a much higher dose than for the sleep. It's between 6 to 8 milligrams for 6 to 8 weeks to have some results, and then it comes with the difficulties that it's not prescribed by you guys. It has to be a hospital prescription by the pediatrician or the neurologist, but if they respond, it is a good option. Also helps if they are not sleeping well, it helps as well, but that's not why we would recommend. On your primary care, I would recommend propranolol and amitriptyline as option. You can try the epizootfen, but for tension type headaches, usually propranolol and amitriptyline are the more effective drugs. And then just talk a bit about the trigeminal autonomic cephalalgias, that it is a smaller percentage of your headaches. And these are the headaches that if you have in your practice, you can give the first advice and everything, but they usually need a bit more investigation. And most of them, you end up having an MRI of their head just to make sure you're not missing something else that is causing the autonomic features. So they are clusters, paroxysmal hemicrania, the Suncta and Suna, which are pretty rare in children, hemicrania cochlear when you have a possible trigeminal autonomic cephalalgia. So in children, what you see, it's occasionally clusters, pretty rare, and paroxysmal hemicrania. These are the two things that will end up in your practice. So, and they are different in presentation, but the headaches are very different from migraine and tension type, and that's when you need to think about them. So they are very severe from the beginning, and it is strictly in one side. And sometimes kids say it's in the middle of their head, but it is a localized point. And and they last anything between 15 and 108 minutes. And the kids are restless. They can't sit still. The pain is so severe that they are walking around, they are hitting their head. So it's not like a migraine that they just hold their head and they want to go and lay down and no noise is around them. They are distressed by it. And you can have the autonomic features. You can have red eye, you can have swelling, you can have redness of the face, but this is much less obvious in children. But you have the intense pain, usually in one side, around the eye, and with restlessness, and lasts up to 108 minutes. And a cluster will not last 72 hours like a migraine. Like a migraine will not last less than 2 hours. So that's your differential as well. The length of the pain and the severity will give you an idea if it is a trigeminal autonomic cephalalgia or a migraine. Again, you have criteria for that. So it is at least 5 attacks of severe or very severe unilateral, orbital, supraorbital, or temporal, lasting 15 to 180 minutes if not treated, and either or both of the following: high redness, nasal congestion, edema on the face, redness around the skin, and the sense of restlessness and agitation. And they usually have between any from 0 to 8 times, 10 times a day. And they can be episodic and lasting from 7 days to 1 year, but having large periods of time with no headache, or they can be chronic when this is much more frequent and with no remission in between. So just as one of the examples, a 14-year-old girl who was referred to my clinic with migraine that was not responding to any treatment. So she had very clear headaches that she described as the first thing she had is the room was spinning. She was feeling sick, having pins and needles on her feet and her things, usually because she started hyperventilating because she knew the pain was coming, and then have a stabbing pain in front of her head and in between her eyes. And that's what most of the kids with cluster will tell you. It's not always in one side, but in the middle of the head. And I described like someone with a helmet or a knife hitting her head. And she felt that her nose was blocked, but she was not sure if her eyes were watery. All her headaches would last 30 to 45 minutes. And during the episodes, the pain was so severe that she couldn't open her jaw, and the face was so painful that she couldn't talk. And she was having this almost every day and happening 3 to 4 times a day, lasting 4 to 5 minutes. So this is a pretty severe pain affecting her attendance to school and affecting her quality of life. So this would fulfill the criteria for cluster headaches. So we made a plan, because when you have a child with symptoms of trigeminal autonomic cephalalgia, if you can have an access to high flow oxygen during one of the attacks, this is part of the criteria. So you give them high flow oxygen between around 12 liters for 15 minutes in a non-breathable mask. And usually the pain subsides between 5 and 10 minutes, and that's your diagnosis. And then you can use this as a rescue medication and then treat her with a prophylactic medication as well. So this girl did, and she responded really well. And then we organized oxygen at home and at school, and I started her on verapamil, which is the medication of choice. And for her, she responded really well to the verapamil, and we stopped it after 6 months. And the oxygen is available if she needs, but she hasn't had any relapse for a very long time now. So for cluster headaches, there is a genetic component. So there are changes in chromosome 1, 2, and chromosome 6 that are involved in diagnosis of cluster headaches. But we don't use genetic testing as part of the diagnosis. Clusters in children are difficult to recognize because younger kids might not be able to tell you exactly what's going after than just crawling into a ball with a severe pain. And the autonomic features that you see so clearly in adults are not always present. And they might vomit because the headache's so painful that they might vomit and want to be quiet. And they might not having blockage in one side, it might happen on both. And there is a high correlation with parents smoking in the house. They're not sure why, but there is data available. So if the parents are smokers and the kids having something that you think might be in the trigeminal type of pain, then think about cluster. So just as an idea, so I think that this table helps to think about what are you dealing with. So if you have a migraine, the attack is going to last anything between 4 and 72 hours. And if you're having a cluster, it will last anything between 15 minutes and usually 108 minutes. And in migraine, it's not always side locked. It can be on either side. It can be the whole head in children. And in the paroxysmal hemicronia in adults is usually in one side, and in children can be on both sides. And then the indomethacin is if you had a child that you think they are clusters and the headaches are lasting anything between 15 and 30 minutes and you are not so sure they didn't respond to high flow oxygen, your next in line is try the indomethacin, because if they are indomethacin responsive, then you know the diagnosis of paroxysmal hemicronia, and then you keep them on indomethacin anything between 3 and 6 months and then you stop, and this is the prophylaxis. Migraine doesn't have autonomic features, but in clusters and in paroxysmal hemicrania, you usually have, but much less in adults. And then acute treatments, you can have any painkillers, you can have triptans. In paroxysmal hemicrania, nothing is going to help. And in clusters, you can try the triptans, the nasal and the subcutaneous and the oxygen. And then preventative, this is more in adults, and I'm not going to go into details for any of them. And in terms of duration, like the clusters headaches will last between minutes and hours. The paroxysmal hemicrania will happen much more frequent, but they are shorter than the clusters, and the symptoms are much shorter with similar symptoms. Again, that's very similar to the other. So in terms of rescue medications and other medications you can use for migraine, so triptans are in the BNF for children over 6. The most common is sumatriptan that you can use nasal or subcutaneous. The nasal, it's easier because it's a spray, and the child, if she's vomiting, they don't need to swallow. Most of the kids tell you that it's a horrible metallic taste and they hate it and it didn't help. But they can tolerate the oral. I never give a subcutaneous to a child. Zomitriptan is a very good option, and you can have the soluble tablets that you put in your mouth, and you can have oral and nasal as well. Rizatriptan and frovatriptan are good options as well, and your teenage girls, when the symptoms are much more frequent during their periods, you can give frovatriptan 2 days before the period starts and 3 days after, so a total of 5 days with significant improvement in their quality of life during their periods. And sometimes the kids only need this and no other prophylaxis. There are new drugs that are not yet available in pediatrics that should be coming in the next couple of years. They are already available in adults, which are the CGRP monoclonal antibodies, which is an injection once a month, and you have the CGRP antagonists, which are the GPANs, and all being used in adults, but not yet in the pediatric population. There are other treatments that you can use, and that we call the neurostimulation, and the idea is kind of neuromodulate the pain pathway, and that includes the nerve blocks, which can be the great occipital nerve block, or the supraorbital, or the auricular nerves, and with good response, but it has to be done in the hospital setting. You have non-invasive stimulation that is also available in adults for cluster headaches, with the vagal nerve stimulation that you put on the neck, but not yet available for children. And the surgical options are extreme and not used in children. Right, sorry, I think I've done a bit longer than I planned.
That's all right, Lucia. We have just had a few questions that have come through the chat. So the first one's from Kenu, who has said, at which age is a kid able to signal an aura before a headache?
It varies. Usually it'll be the older child, but I had younger kids as early as 6 that mainly what they tell is the visual aura. So, and in kids, it varies. You can have at any age. You're not going to have in a child who is 3 years old, and you can have migraines from 3 to 4 years of age. But usually, the older they get, they can tell you a bit more.
Okay. And a second question from Kenu is, are triptans a valuable option?
Are triptans a viable option? Say again?
Valuable option for children with cardiac malformations and migraines.
Oh, yes, that's a question that I have quite frequently. They are not contraindicated, and I had quite a few things. What I usually do if I'm going to give the triptan is just get the okay from the cardiologist, because these children are under the cardiology, and I never had a no from any cardiology, but there is no contraindication per se because of a cardiac malformation. but parents will ask you that, so it's just kind of a courtesy and to be on the safe side, just document that you seek advice from the cardiologist.
Yeah, and then there's a question. Oh, the questions are all popping in now. There's one from Vanessa who said, what percentage of children respond to the vitamins?
About 50-50. And it's
Okay.
not only the vitamins. Talk to them about all the health lifestyles and everything. And just I tell them this is not a boring thing. This is important and will make a huge difference. But it's about 50% they will respond. And if they don't respond, then you try a second option. And after that.
Yeah, and there's another question who's, how far can GPs go with prophylactic treatment in children?
Um, I think if you are comfortable and you can try the first and second line. I think if you try it, like you can try the vitamins, nothing. You can try propanolol or amitriptyline is nothing, and then that's usually when I get the referrals and the pediatricians who get the referral if they failed 2 prophylaxis, and then you are safe to say actually they probably need something else, and then we would accept a referral.
Yeah, and another one's popped in. So, do you have any advice if you suspect the child is fabricating their headache symptoms?
Yeah, that's a tricky one. And that's when it's a partnership and we, especially with the parents. And I always ask it a headache diary that doesn't need to be anything fancy. It's just a paper or on their phone telling you when it hurts and what triggered and everything. And then over time, you're not going to get this on the first appointment. You will get this with a period of 15 days, 20 days of the headache diary, and when parents are on board, but it can be very tricky. And I think if you are suspecting, I think that's a reason to refer.
Yeah, and another one is from Vanessa. Are there any limitations for how often children can use triptans or the long-term side effects?
Um, we, I, what we advise is if they are needing triptans more than twice a week, you need to rethink about the prophylaxis you are using. So as a general for adults and children, saying maximum twice a week, 2 days, because you can have the triptan now and have repeated dose after 2 hours if needed. But it is more than 2 days in a week that you need, and then you need to rethink your prophylaxis. And the same goes for if there are bad spells, there are times when the headaches had a massive flare up or the exams or anything. And if they need to use painkillers, one of the advices we always give is one day you use paracetamol, the following day you use ibuprofen to avoid overuse medication, and no more than 2 days a week to avoid complications.
Okay, we just had one more question, and we'll make this one the last one. Can GPs give a physotipfen, sorry everyone about my pronunciation, for abdominal migraines?
Which one? Pizochfen?
Yes.
Yes, absolutely. And for cyclic vomiting, if you think a child cyclic vomiting, Pizochfen is a very good option. It's a pretty safe medication with the worst side effects, a bit of a tummy pain, and if they don't respond, you just stop it. Absolutely.